Hello, everyone. It's a great pleasure to me to attend the invitation of Professor Cornely to be with you discussing few topics about the Global Guideline for Diagnosis and Management of Candidiasis. I'm Arnaldo Colombo. I'm infectious disease specialist located in São Paulo, Brazil, at the Federal University of São Paulo. And the topics I will discuss with you are related to Candida endocarditis and central nervous system Candida infections. This was a huge work that enrolled several investigators from all continents. Lots of scientific evidence were evaluated to grade the suggestions we're going to present to you according to the evidence. When evidence strongly supports, grade A, grade B moderately supports, grade C marginally, and grade D against. Please follow the colors that will appear along my presentation. Candida endocarditis, fortunately, is not so common in patients who develop fungemia and are not part of the high-risk populations. But definitely, echocardiography, transesophageal echocardiography should be considered for checking the possibility of endocarditis in patients with clinical signs of endocarditis who have developed fungemia, especially for those who have long-term intravenous catheter, patients who have previous heart disease, valve disease, patients with cardiac implantable device, they all should be considered of risk for developing fungemia, and images may be of substantial help besides culture. And as I mentioned, transesophageal echocardiogram usually present a better performance than transthoracic, and sometimes even PET-CT should be requested in case of the images are not present, but patients present obvious conditions suggestive of endocarditis. How to treat those patients? As first-line therapy when all drugs are available, liposomal amphob 3 to 5 milligrams per kilogram, plus or less flucytosine. Alternatives are caspofungin, anidol or micafungin. It's important to consider that device should be removable. Surgery has certainly a place in terms of providing long-term survival. In case of prosthetic valve endocarditis, there are some evidence suggesting liposomal amphob plus or less flucytosine is better than echinocandins. Patients should be submitted to a long period of suppression therapy with fluconazole after surgery. When no candins are available, you don't have options except using liposomal amphob, please remove device, consider surgery. Prosthetic valve, once again, liposomal amphob, and consider to expose your patient to oral fluconazole for a long period of time if patient has Candida species susceptible to fluconazole. In case no lipid formulation of amphob be available, you should use echinocandins. Caspofungin is the best choice with better evidence, but we believe anidol and micafungin may works as well. There is ever the need to remove device, to request surgery, and in case you are not going to be able to submit your patient to a valve replacement, please consider to do a suppression with fluconazole for all lifelong. Adjunctive surgery is necessary. We have some controversial data suggesting impact or no impact in terms of mortality, but there are some large cohorts suggesting that adjunctive surgery may play a role and this is what we suggest you to consider. Combination therapy, we have scarce data supporting this evidence, but yes, it may play a role. It should be considered case by case for refractory patients to first-line therapy, as discussed before. Antifungal susceptibility tests are mandatory, especially because you are going to expose your patient for a long period of antifungal therapy. It's recommended to check for the susceptibility of those pathogens. Having said that, we are moving now to another major complication. That's central nervous system candidiasis. This is a kind of complication that's mostly documented in neonates, premature neonates, or in adult patients who are exposed to neurosurgery or implanted device. Patients with suspicion, neurological alterations, evidence of meningitis should be submitted to a lung puncture. Culture of lung puncture is mandatory. The analysis of biochemistry, data, cytology of the lung puncture is important. Besides culture, we have some evidence that beta-D-glucan may be of any help to support the suspicion. Imaging is mandatory to monitor putative complications. You can have increase of intracranial pressure. You can have abscess that may demand surgery. And yes, imaging modalities, either magnetic resonance or CT scans, are important to follow those patients. In patients who present relapsing or progressive refractory chronic meningitis, neonates, is important to exclude genetic immunodeficiency. And in terms of antifungal therapy, when all options are available, best choice is starting with liposomal ampho-B, 3 to 5 milligrams per day, plus or less 5-flucytosine. In case you don't have access to liposomal ampho-B, deoxycholate, a conventional formulation of B, could be considered. And please avoid the use of any echinocandin as first-line therapy in case of central nervous system infection, especially meningitis. Remove all device, check images to see if there are abscesses that should be drained. Request Candida species identification, fungal susceptibility tests, and in case patients are Candida susceptible to fluconazole, you can consider a long period of treatment using triazoles, oral triazole therapy. Salvage therapy may be required for patients who are intolerant, do not respond to lipid formulation of B. Then you can consider first-line therapy with triazoles that will have good concentrations, voriconazole, fluconazole, as well as caspofungin. That could be another alternative. Intravascular caspofungin. Those are marginally supported by evidence in the literature. In case you have a patient with central nervous system infection, adult patients with no availability of lipid formulation, you're going to use deoxycholate, amphotericin B deoxycholate. That's the formulation that the pediatricians enjoy to use in neonates because toxicity is not that high. You're going to use this as first-line therapy as alternative because you don't have another option. Please, once again, avoid using any echinocandin as first-line therapy. Remove infected device. Check for the occurrence of abscess, brain abscess that should be drained, and consider a long period of drug suppression with fluconazole in case Candida is susceptible to this pathogen. Thank you so much. Thank you, Professor Cornely. It was an honor to participate of this outstanding group who supported this guideline. Hopefully you enjoy reading of this paper and all lectures that are being presented related to the guideline.